Committee will come to order. This morning, the committee will hold an open hearing on the governance review of the military health system. I'd like to welcome the new Surgeon General of the United States Army, Lieutenant General Patricia Araujo, who has not been here in that official capacity before, so we're very happy to have you, although we've known you and all of the others for quite some time. Welcome you to your first visit, official visit to this committee. And the new Surgeon General of the United States Navy, Vice Admiral Matthew Nathan. Same story, we've known him for years. Met him first during a big hurricane down in Pensacola when his hospital was nearly blown away, and his time at command at Bethesda. But again, Admiral, your first official visit before the subcommittee, so welcome to you, sir. And General Green, you're the old timer. You've been here before, and we always look forward to your testimony, and we look forward to it again today. And then Admiral Madison has been before the committee on a number of occasions, and we have had some interesting discussions during those periods, and we welcome him back for this general overview of the governance of our military health system, a health system that is just extremely important. I just want to make just a couple of quick comments before I yield to Mr. Dix, and then we'll go to the witnesses. In today's world, our soldiers, sailors, airmen, Marine, Coast Guardsmen are getting hurt really bad. But because of the advances in new medicines, because of the better training for our medics and corpsmen, because of the ability to move from the battle zone quickly to a field hospital or to a hard hospital, and then quickly on to a hospital like Landstuhl and then back to the U.S., we're saving soldiers who would have died in previous conflicts. Because of that, we have a tremendous obligation to them, and that obligation is going to last for a long time because these injuries, as we see them, and we encourage as many of our colleagues as we can to visit the hospital at Walter Reed Bethesda so that they can see firsthand what it is that this war is actually costing us. Not the cost in dollars, but it's a big cost and it's a big obligation. But anyway, I read this Department of Defense Task Force on Military Health System Governance several times, and I will tell you that it's really interesting reading, and you have to read it several times in order to fully understand it. And I'm not sure that I fully understood it yet, but it is really good reading and creates a lot of questions, and we'll be discussing some of those things. But before we go to your testimony, let me yield to my friend and my former chairman, Mr. Dix.
Thank you, Mr. Chairman. We want to welcome all of our witnesses today, and the subcommittee has had a history of championing for the soldiers, sailors, airmen, and Marines that willingly serve and are truly at the heart of what the services do. We know that taking care of our service members and ensuring that they, as well as their dependents, receive world-class medical care is at the heart of what you do. We also know that governance and military health is a topic that has been widely studied and discussed, but is difficult to change. Today we want to discuss governance of the military health system, and we are interested in hearing each of your thoughts on how the task force on governance proposed structure will enable you to provide the best care possible, as well as what proposals may create obstacles to overcome. We are also interested in hearing how implementing recommendations for better governance can create efficiencies within the system and highlight opportunities for new partnerships, not only between the services, but with local communities and the Department of Veterans Affairs. As for the National Capital Region, we are interested in hearing how the new Walter Reed National Military Medical Center at Bethesda is operating, and with an integrated staff resulting from the merger of the Navy and Army cultures. Each brings their own unique capabilities to the mission to provide care and help service members and their family heal. We are now eager to hear from the new Fort Belvoir Community Hospital is operating. We have also seen a dramatic rise in the need for behavioral health services for our wounded warriors returning from war and assimilating back into their services, their home life, and in the case of the Guard and Reserve, their towns, and cities. These invisible wounds have been called the signature wound of this generation. I believe the health care issue will be one of the greatest challenges for personnel who are currently serving and for veterans as well. We thank all of you for your service, and we look forward to hearing your views on governance. Thank you, Mr. Chairman.
Yeah, Mr. Dix, thank you very much. We understand that you do not have prepared statements, which is certainly not necessary because I know that you all know your issues extremely well. And so we'll hear from you as whatever you want to tell us, tell us. And we're going to listen patiently. We will do our best not to interrupt you as you proceed, but then you're fair game after you've finished your opening statements. Let me start with General Horoho. General, we'll go to all four of you before we do open up for questions.
Okay, thank you, sir. Chairman Young, Ranking Member Dix, and distinguished members of the committee, thank you for providing me the opportunity to talk with you today about the future of the military health system. I'm convinced that we must pursue the most effective and efficient command structures to support the strategic goals of the military health system, the services, and the combatant commanders. There are many ways to realign and consolidate the Department of Defense common medical functions to enhance performance, reduce cost, and increase efficiencies. The Army's position is to organize military health system under a unified medical command or move towards a unified effort in synchronizing the delivery of health care. As the Task Force on Military Health System Governance reports highlights, there have been numerous studies supporting the establishment of a unified medical command or some variation aimed at optimizing the health of the force and the health care outcomes, standardizing health care metrics, reducing redundancy among the services, and reducing unwarranted clinical and administrative variation. I believe there's a strong collaborative effort between all three of our Surgeon Generals as well as the JTF Commander. Our commitment is to ensure we optimize the delivery of health services, to ensure our medical support to each of our services while reducing redundancy, while maintaining unity of effort, and focusing on health. I look forward to the dialogue that will follow and appreciate the opportunity to respond to any of your questions. Thank you.
General, thank you very much. Next, we'll go to Admiral Nathan.
Chairman Young, Ranking Member, Mr. Dix, and the committee, again, thank you for the opportunity to discuss these issues. Also, as the previous commander at the National Naval Medical Center and then the Walter Reed National Military Medical Center, my thanks to all of you for your personal interest. I remember seeing many, if not all of you, at one time or another coming out to the campus to survey the situation on behalf of the interests of the men and women who we take care of. And may I thank the committee also for the funding and the stewardship you provided to allow this magnificent facility to be built. That said, it represents an icon and a new change in the way we do business in the military health system. We have taken the two flagship hospitals of the Army and the Navy, and we've combined them into a premier institution. Certainly not without growing pains, but I am a witness to the synergy that is created when we collaborate and when we bring the best of the services together to find best practices. That momentum is carrying on now as we look for better ways to create efficiencies, transparencies, and remove redundancies, all in the name of finding best value while maintaining best care for the most precious resource in America, the men and women who serve in the armed forces and their families, and those who came before. So I look forward to your questions and the discussion. I recognize that we are in somewhat uncharted waters, as we say in the Navy, as we look for new footing and a new landscape to find a governance structure that will accommodate these efficiencies and these transparencies, and at the same time preserve the amazing combat warfighter support that has been evident over this last decade, resulting in the greatest survival rates and the lowest disease non-battle injury rate in military history. Thank you, sir.
Thank you, Admiral. General Green.
Mr. Chairman, Representative Dix, and esteemed members of the committee, thank you for inviting me here today to discuss the way ahead for the governance of the military health system. This is an important issue that is appropriately addressed jointly by all of us here today, as the stakes for our military mission and for our beneficiaries are very high. The MHS Governance Task Force recommendations are important because they represent the intense and informed deliberation of both line and medical professionals who are seeking the best solutions to maintain exceptional care to our service members, while finding more effective and efficient ways to deliver that care. We believe that efficiency and cost containment are best obtained through an agency construct. I applaud the 2012 NDAA language that requires thorough cost analysis and review by the GAO to ensure we have it right. I'm confident that a comprehensive business case analysis will support the conclusions and recommendations of the task force. Today's military department's oversight of medical assets created the most effective system for treatment of casualties, with the lowest died of wounds rate and the lowest disease non-battle injury rates in history. Our highly capable and efficient expeditionary medical support platforms and aeromedical evacuation operations would not exist without the close alignment of our Air Force medics to the line of the Air Force operational missions. Deployed to our theater hospitals and supporting our AirEvac system, Air Force medics have safely returned 93,000 U.S. casualties to their families from Iraq and Afghanistan. Every day, our medics are saving the lives of soldiers, sailors, Marines, airmen, civilians, coalition forces, friend and foe alike, under the watchful eye of Air Force commanders. Implementation of the task force recommendations will ensure the sustainment of this high level of mission success. It's an imperative for the MHS to have a single financial accounting system to ensure transparency and promote trust and accountability between services. We believe that a more effective and efficient joint medical solution can be attained without the expense of establishing a unified medical command. The services should and will continue integrating common medical platforms to reduce redundancy and lower costs. The task force recommendations will move us quickly to a construct that curtails expenses and achieves savings to the greatest extent possible while meeting our mission. In conclusion, the Air Force Medical Service remains committed to working with Health Affairs and our sister services to ensure the military health system is organized in the most effective manner to provide quality health care to military members and their families, while also being good stewards of American taxpayer dollars. I thank you for your continued support and look forward to your questions.
General, thank you very much. And Admiral Madison, we're happy to hear from you now, sir.
Thank you, Chairman Young, Ranking Member Dix, other distinguished members of the committee for inviting me today. I first appeared before this committee in 2009. This will be my last opportunity to testify before this distinguished panel in my role as the commander of the Joint Task Force, National Capital Region Medical, or JTF CAPMed. Secretary Panetta has approved my request to retire from active duty after 4.5 years executing the BRAC projects and achieving unity of effort in the National Capital Region. I'd like to thank this committee for providing the department the critical support over the past 4.5 years that was necessary to be able to finish the largest and most complex BRAC project, medical realignment project in the history of the department. As you know, Secretary Gates established JTF CAPMed in 2007 after the Washington Post articles about the Walter Reed Army Medical Center to ensure the effective and efficient delivery of world-class military health care in the National Capital Region. In fact, world-class is not just an aspiration for us, it is a statute. And so we are required for the hospitals in the National Capital Region by law to be world-class. As part of our mission, we oversaw the closure, relocation of the Walter Reed Army Medical Center to Bethesda and to Fort Belvoir, where the Fort Belvoir Community Hospital was established. Those projects included, and I'll just give you a few statistics here, construction and renovation of over 3 million square feet of space. The footprint of the Walter Reed National Military Medical Center is the equivalent of the footprint of the Mall of the Americas. The procurement of 160,000 new items of equipment, relocation of 750,000 cubic feet of material, transition of 9,600 staff, including a guaranteed placement program that enabled us to keep the civilian personnel at the Walter Reed Army Medical Center on the job through the heights of the fighting seasons after the BRAC law was passed. We had to reassign 34,000 enrollees in terms of primary care manager. In our most precious mission, we relocated 400 wounded warriors and their families from Walter Reed and other facilities to the new Bethesda complex, which provides extraordinary lodging for them. Mr. Chairman, Ranking Member Dix, I'm pleased to report to you the department completed all of those tasks, and I'm glad to speak about any of the efficiencies that we were able to achieve as we did it. And I think that the record that the Joint Task Force has illustrates the power of achieving unity of effort through joint command, and I'm pleased to answer any questions that you may have.
Hey, Admiral, thank you very much. Thank all of you for getting us started here today. And at one point, I thought it would be appropriate to do an overall governance hearing and then do a separate hearing for the merger of Walter Reed and Bethesda. The more I thought about it, the more I realized you can't do that. It all works together. It's all part of the same system, and we need to make sure that all of it does work. On the task force study that I mentioned earlier came up with a number of options as to how we should proceed at this merged facility. And I think it's been said numerous times that this is probably the most complex, the largest merger of medical facilities anywhere. And I can understand that because Walter Reed is in my opinion, a world-class military medical facility that took great care of our soldiers. And I know you mentioned there was a problem with Walter Reed a few years back, and there was, and I'll mention that in just a minute. And Bethesda also, a world-class, I think I have witnessed miracles at Bethesda and at Walter Reed. People who lived when I don't think anybody really believed they would. Now, to me, that's a miracle. And I've seen them in both hospitals. In fact, when the Walter Reed issue, Admiral, that you mentioned came up, I took a lot of lumps because I took the position that, first of all, that problem had nothing to do with medicine. It was a trashy building that even the then Army Surgeon General had admitted that he didn't know that it existed. And it was housing people on med hold. And so I took the position that aside, Walter Reed is a great military medical facility. Took some lumps for that because there are some that thought I should have really jumped on the bandwagon and beat up on Walter Reed, which I just wouldn't do. But anyway, the task force came up with a number of options. None of the options got a majority. There were 9 members of the task force. One option got 5 votes, and that's the only option that they got 5 votes. And the way I read that option, and by the way, the Army and the Navy both supported that option, which we'll refer to as option 2, suggested that a Defense Health Agency would be established replacing TMA to consolidate a far broader set of shared health support services, MHS-wide. Shared services activities include, but are not limited to the TRICARE health plan. But it basically, without going through the whole language, it basically suggested that the merger should be managed by a joint organization created by and with the approval of the Army and the Navy. And that's the only one that got 5 votes. None of the others got 5 votes, so, and I don't know what the decision at DOD is going to be. But now when I listen to Admiral Madison, the Joint Task Force is in addition to the Army and the Navy running the facility. Am I correct there?
That's correct, sir. I have command and control over the Walter Reed National Military Medical Center and the Fort Belvoir Community Hospital.
And so you're telling me that the Army and the Navy then, they report to you, or do they report to their surgeons general, or?
The commanders of those hospitals report to the Joint Task Force. They report to me. There is a relationship to the services that's called ADCON, administrative control. It is a route through which fitness reports and other administrative matters pass.
But that system is not what the Joint Task Force, or not, it's not what the task force voted for. Correct? The option, are you familiar with option 2?
No, sir, I was not a member of that working group.
Oh, but I thought maybe you might have read the report. So the decision is still out. BRAC supposedly is to consolidate and to save money. Seems to me the Joint Task Force becomes a separate layer in addition to the Army and the Navy, who have traditionally run those two hospitals, which are now one. We haven't received your budget yet. We haven't received any of the budget for any of the Defense Department yet, and we're anxiously awaiting that. But I look at your budget for FY12, and I see that your JTF headquarters staff is the budget is $11,723,000 with 119 full-time employees and X number of contractors. Do you know how many contractors you have plus your regular staff?
Sir, we had a great many during the BRAC processes, a lot of program manager and others, and we've attrited most of those now. If I might address the question of what's the size, right size of the staff. An apples-to-apples comparison is necessary to take a look at different governance structures, so that when you take a look at running, for instance, a market, as is described in San Antonio, you also have command and control layers. And so each of the services has command and control headquarters in San Antonio, for instance. Here in the National Capital Region, if there is a joint task force, and I think this gets to the point that of the GAO studies, if you can reduce those intermediate levels of command, you can find efficiencies. So the only way that the JTF is not efficient is if you take a look at, as a model, is if you take a look at what are the command and control costs for the services. What does it cost to run the North Atlantic Regional Medical Command, Navy Medicine National Capital Area, and the 79th Wing, and how can something like a JTF with only 117 people reduce that level of effort? I provided information to the chairman of the working group that showed that we would be cost neutral at worst and be able to find efficiencies if you take command and control into account.
I don't think I see this any place, but I'm curious. Is it the intention that Joint Task Force will eventually reach out and absorb other military hospitals and clinics that are not presently subject to JTF?
That has never been a matter of intent in the department, to my knowledge.
Okay. The Army and the Navy coming together is going to be problems. Anytime you have a merger of any kind, there are going to be problems. But my understanding is that your Army and Navy commanders are really working things out fairly well. But I wasn't so sure that I wasn't sure they had the report to JTF, and I don't understand that because BRAC itself, the BRAC law, did not create JTF. But anyway, that remains to be seen what the Defense Department is going to decide to do on those various options. Well, I have a lot of other questions, but I don't want to use up all the time today. And I will get back to you on some other questions, but I want to yield now to Mr. Dix.
Yes, I want to, is this system on?
Press the button.
I know, I did, but it wouldn't come on. I've never been known not to be able to be heard, though. Don't you laugh. Anyway, I wanted to ask Lieutenant General Warhol, who had served as the commanding officer at Madigan Army Hospital. There's been some press accounts of concerns at Madigan, and one of the things that I just heard about in the last few days, a program that this was extremely successful. But it was canceled. And I am told by my sources that it was canceled because they came up with too many recommendations that the patients had post-traumatic stress disorder, and that Colonel Kepler and others, were enforcing, I don't know where this came from, but were enforcing a return to duty standard, and we're not very interested in seeing that, and characterizing the people who had been diagnosed with post-traumatic stress disorder as malingerers, which I find offensive. And you've taken certain actions here, but I'd like to know why this intensive operation program, which I told was absolutely a great program of treatment for these soldiers, was canceled. And I'm told that there's been emails sent to my office about this. I don't know if you've seen them. I guess you have seen them. And I just want to get your take on this, gentlemen.
Yes, sir. Thank you for allowing to comment on that. Actually, yesterday it came to my knowledge with the concerns over that center, and I had already initiated on Friday a 15-6 investigation to look into the practices at Madigan Army Medical Center and in the Western region, and to look specifically at the variance with forensic psychiatrists and psychologists reviewing behavioral health diagnoses. In addition to that, last night I actually expanded the investigation to include the intensive outpatient center so that we can understand why it was actually closed. Was there undue command influence in closing of it? Has it had any negative impact on our patients? Since the closure of it, those capabilities in the program have actually not gone away. They've been merged into the other behavioral health programs that they have there. And so there still is intensive outpatient capability. It has just been merged into their primary care behavioral health programs that they have. Having said that, we are going to investigate to make sure that that's actually true and that we're providing the best care to our service members.
Is there a standard, is the Army leadership saying, return to duty is our number one priority, and are putting pressure on these doctors like Kepler to come in with decisions that, I'm told that Kepler would take files and change the diagnosis without talking to the patients. Now, is that acceptable for somebody who's with his background? Can he just take a file and change the diagnosis
Sir, if I can.
without seeing the patient?
If I can address the first part, and then I'll address the second part, if you don't mind. Absolutely, the Army is not putting pressure on any of our clinicians.
It really sounds like it, and the Army has had a history here. We've had hearings before where there was a analysis done of the Army versus the Navy and the Air Force, and it was found that the Navy and the Air Force had a higher rate of disability than the Army. Now, that's hard to conceive of, but in other words, they were fair, or as you said, you've got a new standard of give benefit
The
of the doubt.
benefit of the doubt, sir.
Well,
Yes, sir.
apparently, the Army's had a long history of about being more concerned about money, frankly, than the soldiers. And I have great confidence in you, but you've got to get this straightened out. And apparently, there's a problem at Landstuhl as well, which is mentioned in this thing. But we can't be getting rid of an intensive operation program because they came up with too many diagnoses. Either a person's got post-traumatic stress disorder or not. And I don't see how a doctor can change the diagnosis without seeing the patient.
If I could just explain with forensic psychiatrists and psychologists. One, we have removed, removed Dr. Kepler why this investigation is ongoing, and I also have an investigation ongoing into Launchstool with their behavioral health practices across Europe. I am, sir. Yes, sir. Absolutely, and that's part of what we've got ongoing. So I am looking at the entire spectrum. I've got a team that's formed so that we also have an IG. I've asked Department of the Army IG to actually do an evaluation and investigation as well on the practices. So we are looking at this from a very strategic. With forensic psychiatrists and psychologists, what the practice that was a variance at Fort Lewis is that because they had that capability there, when they had patients that were going through the integrated disability evaluation system, when they had a diagnosis that the disability evaluator was unsure of whether or not it was PTSD or not, he then would refer the cases to forensic psychiatry. And then what they do is it's all administrative. It's not a patient encounter. And what they would do is they look at all sorts of administrative data, and then they make that diagnosis. So that's why there wasn't a face-to-face encounter with it, because it's actually not treatment. But that variance is not how we handle the disability process across all of Army medicine. And so it was an unfair disadvantage to those service members. So we've suspended that.
I was told that for a long time, the treating physician would write up a factual paper about the condition of the soldier. That was then taken away from the primary physician and given to a board to do. Why was that? And the people who were giving these things felt that it was improper to do this. That the physician who had looked at the patient, talked to the patient, diagnosed the patient, should be writing up the report, not some board. You know anything about that?
No, sir. But I will ensure that that gets looked into. You have my pledge that I am looking at this very, very hard. We take it serious.
I got to tell you, General, it is hard for me to believe that these doctors are doing this on their own. There has to be some direction. You know, I'm told that your deputy was involved in this and in changing the way this system was when you were at Fort Lewis. I hope that's not the case, and I hope you didn't know about it. But that's what we're told.
Okay, sir, I will have all of this evaluated.
Thank you, Mr. Chairman.
Okay.
Thank you very much, Mr. Chairman, for, first of all, including me in this process, since I'm progressively on my way out of here, but nonetheless.
I should point out that you served as chairman of this subcommittee for years.
Thank you.
As well as
Thank you.
chairman of the full committee for a brief
Thank you, Mr. Chairman.
Nice picture of Paul.
Yeah, General Hirano and gentlemen, welcome to the committee. And first, let me say that we are very proud of the services that you provide to all of our service members across the board. And quality has to be our number one objective, and I'm absolutely convinced that it is. I'll come back to you in a moment, General, to talk about the Army on a more positive note, but in the meantime, in many, many years before Congress, I made an honest living in the private sector. And I very early on made the decision not to do business with physicians because they didn't know how to manage their own office, let alone respond sensibly to ideas that were outside of their realm. Even though they're considered to be gods once they go through residency, sometimes you have to scratch your head. So having said that, as we go about reorganizing the way we're managing hospitals and delivering that quality service to these people, I'm very concerned that we might have managers who have similar levels of experience at management trying to make these changes. Change for the sake of change in terms of the way we coordinate service delivery at the hospitals, coordinate a better capability of delivering care for the physicians, ought to be our priority. But a careful examination as we progressively go forward to this, that might suggest we got to undo this idea and start all over again. That should not be beyond the realm of your responsibility either. Admiral Madsen, as you are going to be retiring from this, perhaps you'll be in a position after that fact to come back and criticize what all these people have been about. But it's really important that we examine and re-examine. Now, from there, relative to your question, Mr. Dix, as it relates to PTSD, the Army in our own region has an ongoing experiment. It happens in my district at Loma Linda University Hospital, where they're dealing with pain receptors and other elements of PTSD, its diagnosis, care, et cetera, that apparently the Army is very fascinated with. And there's an ongoing relationship that it's expanding that seemingly is producing some positive results. And I'd hope, General Hirano and others, that one would look at those models that are working to help each other better understand what successful avenues we might be following. This is largely at a rumor level, but it concerns me a lot. Early on, when this member arrived in the nation's capital, it was suggested that if we ever had any serious medical problems ourselves, that we really ought to avoid Bethesda, for Walter Reed was the place to actually get some care, in spite of some of the controversies we saw relative to personnel, et cetera. I agree with you that we ought to be dwelling on the positive that was taking place there, too. But that kind of myth around the halls of Congress was a reflection where some concluded that one group, one organizational delivery of healthcare systems was working better than others. I hope to God that, first of all, that wasn't an accurate reflection. But secondly, if there was any truth to it, I hope to God that we don't bring these two groups together now at the Bethesda location only to misorganize the whole process. I hear lots of complaints about traffic around Bethesda, but that's almost beside the point when you're talking about high-quality care and delivery. So with that, I appreciate very much your being here, and I'd love to have your response to know if you're aware of that which is taking place experimentally at Loma Linda. And then beyond that, it seems to me it's important for you to know this committee wants to deliver the money for the best possible care, and we will, but we're in it together to make sure that we use the money well. So thank you.
Thank you, sir. We are actually working aggressively to have collaborative partnerships with a lot of our universities that are out there, both in pain management with PTSD and also traumatic brain injury.
Correct.
And the other area that we're looking at is evaluating whether or not tau proteins actually have an impact on PTSD symptoms and the way that we manage concussive care. And so I think there's tremendous opportunities as all of our services together partner with the civilian sector to look at best practices out there. And so that's one of the outreach programs that we are looking at. And then on the business aspect that you mentioned, one of the moves that we have ongoing right now across Army Medicine is moving towards an operating model company. And so we're working so that we decrease our variance and we make sure that we have standards, not standardization, but standards across all of our military medical treatment facilities in the Army so that we look at outcomes and best practices.
Another line of thought, if you will, Mr. Chairman, the National Institutes for Health, they're just down the street from Bethesda's location. I've learned over the years that there truly are some phenomenal people there as well, doing all kinds of things that take us right to that cutting edge. I don't know how aggressively or actively that this new coordinated effort at the Bethesda location will institutionalize a regular communication that goes both ways between NIH and our new institutions. Could you respond to that, gentleman?
Yes, Mr. Lewis, I can speak to that. The National Institutes of Health is literally across the street from this wonderful medical center, America's Medical Center. And we've already started relationships, for instance, with the National Cancer Institute. We've co-located many of the cancer centers of excellence, which were sponsored in the past by this committee and others. We've put them together in a comprehensive cancer center. So it's the first comprehensive cancer center in the Department of Defense. And we're working with the National Cancer Institute to gain NCI, Comprehensive Cancer Center designation. In fact, we're going to expand on that partnership to be able to make the latest in cancer protocols available not just at Bethesda, but across the entire military health system.
Well, the NIH is really very much on the cutting edge of cancer, identifying the causes of cancer and cancer treatment, and indeed, it's that sort of coordination that I would very much encourage and appreciate. Thank you.
Thank you, Mr. Chairman. Like other members, I want to pay tribute to the remarkable men and women that work under you, that have delivered our wounded from Iraq and Afghanistan, and done it in a unified way between the services, through Lance Stuhl and to Walter Reed and to Bethesda, some to Brooke and some out to Washington State. It's remarkable what's been done, and I think we thank you for it. The Task Force on Military Health Systems Governance, so 3 of you have served on this task force, is that correct? This is sort of the focus of our hearing today. So are you intimately familiar with this final report?
We're familiar with the report, sir, but I don't think we actually were members of the task force itself.
But the Army and Navy have bought into the report. So are we able to talk with you and get some answers to you as to why your services, the Army and Navy, endorsed option 2? Are you prepared to sort of talk about that? Or?
I think we can speak to...
This is the future here.
Yes, sir. I think we can speak to the genesis of the task force and why it was established, and then to some degree, as it has not been officially released yet, to some degree as to why certain options appeared better than others.
Well, under this option, military treatment facilities would remain under the respective service that has historically operated them. Is that your understanding?
Yes, sir. The command and control of the operational aspects of the military treatment facilities would remain under their respective services at this time, and then there would be an agency that would be created to share administrative services and to co-locate those.
Yeah, this is a $50 billion enterprise. I think remarkable things are done in each every day, but there is always the constant comment that this is the Army medicine, there's Navy medicine, but in reality, we hope that anybody who goes through that door would there'd be a commonality of service delivery. Yes, Admiral.
Sir, if I can, I believe the part that you're reading, in my understanding, was that related to the concept of markets. And so in these markets, where we have multiple service hospitals, they would remain under service control. That is separate from the discussion about what happens in the national capital region, just for clarification.
Yeah, we could be Walter Reed centric here for quite a long time. I'd like to sort of get a better idea of the broader picture here. And 5 of the 9 members of the task force voted for the military health system option 2 to establish a defense health agency that would focus on consolidating, delivering a broader set of shared health services and implementing common clinical and business processes, which, of course, you mentioned. I just wondered if any of you had any views as to what are the strengths of that recommendation.
Sir, I think I can talk to that. My secretary actually says it fairly well. When you're dealing with an entity that has mission problems, you look towards a command. And so basically, when you have a very difficult mission, such as the integration of 2 hospitals, you set up a command to run those 2 hospitals and ensure that the chain of command is very clear. But when the mission is actually being accomplished well, and I now point to what we've done with Warrior Care in terms of bringing people back from the theater. Sorry. When the mission is being accomplished well, then the question is, if you want to do that mission more effectively, more efficiently, then that is probably the purview of an agency which will focus on the business processes and try to get us to some joint standards that basically all of us would then attend to. So
You don't have joint standards now?
No, sir. We tend to execute through Army, Navy, and Air Force.
But I assume Yes,
It's-
General.
Sir, if I can comment, one of the things, when this report went forward, each of the services had the opportunity to comment on it as it went up to our Chairman of the Joint Chiefs. Army went on record that our preferred course of action was a unified medical command because of the unity of command from continuity of care of the battlefield to how we deliver care across all of our military treatment facilities. We are very much in support of looking at how do we collaborate and share services to see where we can find efficiencies. But the one concern is that the focus of just being on the delivery of health care and not focusing on the full spectrum of providing care in a war zone or humanitarian effort, because that's the full spectrum of what we provide.
But if you take, all the servicemen and women have been subject to TBI, traumatic brain injury, I assume there's not a Navy or Army way of dealing with that. So if you look at unity of purpose, how are we assured, does the new model provide for that, or does it exist now?
It exists now to a great extent, and all of us, I believe, speaking for the Surgeons General, have a collaborative spirit where we all agree that we need to find efficiencies and joint policies and standardization, both for fiscal conservancy and for quality of care. The question is, how do you get to the final endpoint of a joint concept, whatever that may look like, ranging from a unified medical command to a joint operating center with components. And the task force looked at ways to methodically reach that in looking at the multi-service market management areas around the country, coalescing those first, using funding and some command oversight and joint business plans in the areas to create jointness in those areas. It's a little different than the paradigm that exists in the capital region right now. For all intents and purposes, care at Walter Reed and Bethesda, and Mr. Lewis, you brought up, was there a distinction between the care and was one better than the other, was really the same for many, many years. Those staffs have been driving back and forth, operating at both places, and the physicians who work there and practice there, many of them, practiced in both venues. And so it was a great way to socialize cultural integration and acceptance prior to coming together. So the staffs have been working together for years between those two facilities. Now, how do we harness that synergy now that we're all together? How do we harness?
Well, are you all together? I happened to read what's called the MHS stakeholders report. I was struck by the fact that none of your, or at least in your case, your predecessor, that there's any mention of any of the other services in that stakeholder report. Part of what we're talking about here is overall governance, and then the phrase changed, interoperability one day, jointness, 2 years ago, unified effort. I think what we want is actually a unified effort. It isn't reflected in a pretty basic document, which I think most members have here.
And sir, I believe we want that too. There's some great examples, such as the enlisted training now that occurs in one location in San Antonio. The Navy has folded its tent at Great Lakes, the Air Force at Shepherd. We've relocated all our training. The majority of our enlisted medical training now occurs together in the same classrooms by tri-service instructors and civilian instructors. And so I think we're seeing the seeds of jointness. I grant you, sir, the inertia of the system does not lend itself easily to all coming together rapidly. But I think if we can do this methodically, and if with the collaborative spirit that exists here, we can find the right milestones to get there.
Okay, thank you, Mr. Chairman, for all of it.
Would you yield just a second?
Be happy to, Mr. Chairman.
Admiral, your discussion of how the Army and the Navy, Walter Reed, Bethesda worked together for years, and I think many of us are very aware of that and the fact that it worked very well. Was there a JTF type organization over and above your joint operations with the Army and the Navy?
Well, no, sir. The JTF organization came into effect as BRAC was decreed, to be the oversight agency to help coordinate many of the functions at BRAC.
So you did a pretty good job without that extra layer of bureaucracy, which I prefer to call it because it's what it seems like it is to me. Mr. Visklowski.
Thank you, Mr. Chairman. Panel, thank you very much for your service. The task force completed its review and reported recommendations to the Deputy Secretary of Defense in September. One of the assertions is that the task force review lacked cost savings estimate associated with the organizational restructuring. Have your services and organization participated in cost studies regarding the possible implementation of the recommendations? And what are the results of those studies?
I'm not aware of a formal study by the Navy as to delineating savings that are captured in the task force, other than evaluating various COAs as to their efficacy and leading towards a more unified command and control element.
And the Air Force has not done formal cost analysis. I think that the only thing that has been looked at is what has been presented with relative numbers of manpower that would be assigned to the various structures that were proposed.
And that would be the same for the Army, sir.
On the multi-service market governance models, option 3 was selected by 7 of the 9 task force members. Does the governance model effectively streamline traditional overhead and administrative costs? Or, to use the chairman's word in his closing remarks, are we adding another layer of administration?
Sir, the problem, and if I could address the previous question as well as this one, we have very clear clinical guidelines in terms of how we practice the same medicine. But when it comes to business practices, our business practices are aligned by service. Because when you go back to how the joint doctrine was written in Goldwater-Nichols, essentially execution is done by each of the services. And so money, for instance, the Defense Health Program, starts off as a joint appropriation and then is given to each service, where it's then executed by the service through their own financial systems. And therefore, there's not the transparency that's perhaps necessary to look at some of the cost cutting and things that need to be done if you were to look across the services in terms of what's expensive and what's not expensive. And so we have been talking for some time about how do we improve our financial accounting and essentially take a joint appropriation and make it so that it was tracked by a single service financial system. But it goes beyond financial systems. The Air Force is the only service that doesn't currently have functional commands. And so today, I sit before you not as a commander of a medical command, but as a staff officer that works for the Chief of Staff of the Air Force. My influence over the various wings and their medical units is through how we basically oversee the money, and the transparency of how we basically ensure uniformity in terms of how the Air Force practices is by how we administer money. When on the other side of that, if my counterparts were to talk, they actually have a command, and so they have other authorities that they do. Those differences in terms of how we administer and do our business processes are what I think Representative Lewis was referring to when he said he didn't like doing business with doctors. In essence, you know, we tend to align to our line counterparts so that we are basically practicing and trying to be effective, similar to how our line is. That's how we built the AirVac systems. We knew that we had to be light, lean, and capable and fit on every plane in order to come back. Some people refer to that as cultural, but it's really not just cultural. It's execution of business plans. And so when you try and bring those business plans together, the question is, are there common services that basically would create efficiencies across the 3 services? And that's where we were looking in terms of the task force. That's how the task force was looking to see what are those common functions that could be brought together to create better transparency and therefore better efficiency.
So, General, what's your answer? Do you think the system will be more efficient because of this? And you mentioned transparency, and costs clearly matter. But in this case, we're specifically talking about people's lives and their health. And so I think everybody on this committee wants to make sure we're spending every nickel we have to, but we want to make sure we're spending it as efficiently as possible. Do you think it is going to lead to efficiency? You've mentioned discussions taking place as far as making sure there's greater transparency. Are those talks ongoing? Will there be recommendations coming back to the subcommittee about that?
Because the decision has not been made, we have not seen anything in terms of the decision on the task force's work. I can't answer you in all honesty as to what the department is going to do. But from my perspective, if you don't have that transparency, you cannot judge what is effective and what's not in terms of when you compare the programs. It's one of the problems we have today as we compare. We have the same vision for the quadruple aim. We are all working in medical homes. We have done things to try and equalize the systems, and yet the way it's implemented across the three services makes it difficult to actually look at which one is most effective and most efficient. And so in answer to your question, I guess I would tell you that when you look at the joint doctrine, there are many problems associated with when we talk joint. And I've been in joint positions for 8 of my 34 years. The first one starts with Goldwater-Nichols, and basically, if you read it, doctors, lawyers, and chaplains do not have joint positions. And so that's an oddity, okay, which actually we get to deal with fairly frequently. And so it makes it difficult for people to understand what you even mean when you say joint medical. Now, getting past that, which is simply a legal issue, and coming to the next step, we have trained our people in different systems. So stepping into METC and having our training of our folks in terms of their clinical training be identical is going to help us a great deal to understand where we can work together, and where, for instance, if you were trying to be interoperable and wanted to send an Air Force medic into an Army 68 Whiskey role, what training would have to be added. So, I mean, I would not put my people to that role without going through some training that the Army has created for their folks because of the different mission when they are on a helicopter. And so it's those kind of things. My answer to you is that we need to grow into this, and we need to grow into it by looking at those things that are common, where we do agree, and then we can build to it. Whether ultimately it's a joint command or a defense health agency or none of the above and just a collaborative agreement between the surgeons, what we need is ways that we can grow to find things that are more common, that we basically run the finance. I believe that the financing is key, that if we can get to a common accounting system, we'll start seeing the waste. And I'm not talking about waste that goes towards patient care. I'm talking about waste in terms of administration.
I think that the key to evaluating all of the options that are proposed is in relation to authorities. It's one of the keys. Because, and I think that the care is absolutely phenomenal at both Walter Reed and at Bethesda. We had a great success crossing over staff. However, in business operations, we gained no efficiencies through the market that was in operation in the National Capital Region before the JTF came into existence. And so it's more about business process, and unless you have the authority to consolidate assets, you're not going to be able to find efficiencies. And I'll give you 2 examples of what we've been able to do recently. As we moved and consolidated call centers and our human resources center, by moving from 2 or 3 systems to 1, we're able to achieve a cost savings of $830,000 a year, and just on the civilian human resources center that we use, and $240,000 a year in the call center. That comes through being able to direct people into a common location. You have to consolidate if you want to find shared services. And then moving to optimize the operations and the size of the workforce. And you have to have the authority to be able to mold that workforce to find the efficiencies that I think are necessary.
Thank you very much. Thank you, Mr. Chairman.
Thank you, Mr. Visklowski. Admiral, you caught my attention there on that last statement. Curious, what qualifications, what experience, what training do the staff of JTF have that makes them better at this job, this responsibility, than the surgeons general who have been running military medicine for years?
I think we have no different knowledge, skills, or experience. What we do have is a command and control authority that allows us to execute, the authorities to execute the mission that we've been given. When you're able to execute across the Army, the Navy, and the Air Force, and do it effectively, you can find efficiencies. We don't have any more knowledge. It's not a special secret. It is purely, I believe, a matter of the authorities and how you exercise them.
Well, this seems to assume that the Army, Navy, and Air Force can't do the job, at least not as well as JTF. But they have been doing the job for many, many years. And I've been here in this institution for 41 years, sure. And I'm very familiar with the operations at Walter Reed and at Bethesda over those many, many years. And as I said earlier, I believe I have witnessed miracles at those two hospitals. And I have not had that much experience with the Air Force hospitals, except when my son was there and had to go to the hospital at one point. Anyway, let me yield to Mr. Kingston.
Thank you, Mr. Chairman. Admiral, I wanted to follow up on that a little bit, but it's a question for the panel in general. In terms of the command and authority, as I understand it, the Joint Task Force, CAPMED, will report to the DOD, the Secretary directly, right? Or is that?
That's correct. Our charter has us reporting directly to the Deputy Secretary of Defense for now.
Okay, but everybody else would go to their own service secretary and their surgeons general.
That's correct.
Where I'm having trouble following things on this hearing and where we are right now is I don't have an organizational chart or a schematic. I think it'd be very helpful for members of this committee and also of Congress to understand what is the chain of authority and how does that organizational box look and how will it be changed. Do you have such a document?
Sir, I do not, but we can.
Well, I mean,
we'll take that request back.
I'm just necessarily asking you, but does one exist?
Sir, we have our own individual organizational structures, but there's not one that shows what is and what will be. That analysis hasn't been done by the governance task force.
Let me put on a different hat. Down the hall, I chair the Agriculture Subcommittee. And we're working with the Secretary of Agriculture on reorganization. And he's come up with a whole list of efficiencies, number of offices that can be consolidated, closed, number of employees who can be bought out, leases on cell phones, leases on office space all over the country. And I can follow what he's doing. But what I'm hearing today is that there's going to be a lot of functions that can be reduced, and we're looking to find efficiencies, and we're looking to find standardizations, and we're looking to work together. I don't quite understand why we're still looking, to the degree that my assumption would be you've always done that and you've identified it. And what I would love to hear right now is, here's what we figured out. Of all the square footage that we have, we can consolidate these. And the numbers are right. You have 56 hospitals, 363 clinics, and 282 dental clinics. Is that right? Something like that? Mm-hmm. It would appear to me that right now you would be saying, we have eliminated 10 of them because we decided they did not need to be freestanding, and then we combined 27 of them because we figured that the Marines and the Navy and the Army could all go together under one roof. But I'm not hearing that.
Sir, if I may, certainly I think each service is now looking very hard at each medical facility, be it a clinic or a hospital, and to its value both in purposes of training, patient care, and the ability to care for wounded. To echo what General Green was saying, even though those hospitals may have to remain standing and cannot coalesce because they're not geographically as proximal as, say, Walter Reed and Bethesda was. There's no reason we can't regionally look at reducing overhead administratively, combining functions, and that's what the task force is
But
taking us to.
Admiral, what is the budget's gone from 2019 billion to now, is it 51 billion? Is that? And it would appear to me that somewhat without being asked and without having a task force or study that we would have those numbers. I'll give you another example, USDA. The secretary asked his employees, how many of you turn your cars in every 2 years? Nobody, not one person raised their hand in this interagency discussion they had. And he said, so why should we? And it was just these common sense things that did not take an act of Congress or, a lot of bureaucracy. And what we're all proud of the work you do. But we just heard the General of the Air Force and the Surgeon General of the Army say that you don't have, and I wrote it down because it caught my attention, you don't have cost analysis. Is that?
We don't have cost analysis for this, formal cost analysis from the service for this particular task force recommendations. We weren't asked, the services weren't asked to include that as part of their review for this particular task force recommendations. However, we're all extremely vigilant, and many of those common sense decisions have been made. If you look at the Navy, I won't speak for the others, but if you look at the Navy map of medical centers and facilities today compared to just 10 or 20 years ago, no longer is there a Philadelphia, a Long Beach, a Naval Medical Center, Oakland. We have closed some clinics overseas. We have taken other commands that were full commands and converted them into clinics with smaller administrative oversights, mostly because we've looked at bang for buck. Can we reduce the size of them? Can we eliminate them? Will the beneficiary population tolerate it? And in those cases where we have, they have. And so that's an ongoing process within the services. This goes above what we're looking at now. It goes above and beyond those intrinsic efficiencies we find in our services and looks for even more common ground where we can share administrative systems among ourselves.
Well, we're concerned because this committee on a bipartisan basis has always felt that we have to be very careful in terms of the budgeting and not just, we do believe that the military services has to have a very careful look in terms of across-the-board budget cuts. But if the rescissions come in next year, 2013, and that act swings in the direction that it will, we want to be prepared now, and it would be so useful for us to be able to tell our colleagues that you have gone out of that litany of offices. Here are the 6 or 7 things that you have done that we can walk out of this hearing and tell people about. And I can do that on USDA. But I'm going to walk out of here today a little bit blurry. In fact, real blurry, just as I came in. And that's why, to me, that organizational chart, and the organizational chart traced back to your budget in each box, which was one of the chairman's first questions, because we need to work with you. We want patient quality to be the absolute best. That's a given. But we've got to also be really hard on ourselves within the military family and in the committee.
Sir, if I may, the majority of the cost analysis that happens because of the financial accounting by service is through the services. So for the Air Force, from the time I came in where we had 140 hospitals, today we have 15. Of those 15, 3 are joint, 5 are in geographic remote locations, and so we've done a lot of effective and efficiency strategies in terms of how we're going to structure things. And even before the BRAC, I can tell you that the Air Force had 300 to 500 people that were working in other service hospitals, and today we have people that are working in various universities to maintain trauma skills for when they go to war. Even the single appointment system up here was first built down in San Antonio with the consult and appointment management office that was built back in 2004, where we invested nearly $1.5 million from the Air Force into the BAMC structure to basically locate that there. And currently that's where the Wounded Warrior Transition Unit is. So there's a huge amount of cost analysis that goes in. It's typically done by service, with the exception being what's done at market levels, such as San Antonio, where we made the decision to go to a single. And this is prior to BRAC, so it doesn't have to be forced.
Yes.
There are things that BRAC did, for instance, when we worked with the Army at McCord and Pope. Basically, the Army picked up that mission, and we did very, very small clinics simply to take care of some Air Force-specific needs, such as some of the flight clinics that we do. And same thing up at Richardson and Elmendorf in Alaska, where the Army didn't bring in a lot of additional assets when they brought 10,000 additional troops into the area, because the Air Force built that up and essentially established more services in terms of Elmendorf so that we could support the Army folks coming in. So it tends to be built based on the markets where we have those collaborative arrangements. Otherwise, it's done by service. And then Health Affairs creates the overarching rules that we look at each other in terms of what the incentives are and how we get money. So there's a huge amount of cost analysis, but it's done by service.
Mr. Kington, you yield for just
Yes.
one quick question. General Green, your comment about you had several joint operations now, is that correct? Yeah.
Assignments you're talking, sir?
Yes, you,
Yes,
you,
sir.
you said that you had.
I was the CENTCOM surgeon and the TRANSCOM
Right.
surgeon. And
Uh,
I have part. I take part. I have people. 2,000 people now at SAMC in San Antonio. 300 people that work in Landstuhl at in Germany, and about 150 people that work here between Bethesda and Walter Reed. I'm sorry,
Okay.
Bethesda and
my
Belfort.
question on that is, do you have any organization like the JTF that's sort of a superstructure over that jointness?
No, sir.
Thank you.
Well, for the joint hospitals, I have ADCON back to the organizations that are in that area, which is what Admiral Madison referred to.
Mr. Chairman, I know I'm out of time, but I have a question that's right on the back of yours. And I would like to know, what is your view of the relationship between the command of JTF, CAPMed, and the hospital and installation commanders? Is that a good relationship, or is there dynamic friction? And is it positive or negative? Yes.
There is friction. I think that the JTF was very much required to integrate two very large facilities into a single operation for the BRAC. But from my own personal perspective, because we don't have joint credentialing guidance and joint nursing policy and joint patient administration, we really need to operate the hospitals today by one service's rules. And so there's friction because the JTF would like for us to move towards more joint oversight, and because that doesn't exist yet, trying to move in that direction is difficult.
Thank you, Mr. Chairman.
Thank you. I'm going to join Congressman Kingston. I came in here to learn and to ask some questions, and this seems to me muddier and muddier. And what we're trying to do, of course, is to deliver quality health care in a time where, you know, our men and women are coming back with some terrible, terrible situations, and we do it in an effective, efficient way. And to do that, because we are in a crisis and we know what's coming down, it's more cuts, and so you've got a quagmire here, it seems to me. And are you moving toward that solution? Because it has to happen. I mean, it can't continue. I had a base that was in my district that was set for closure and then realigned as a joint reserve base. And for a while, it looked like instead of saving, we were going to spend as much money as we could to put walls so every branch of the military could have their own set of circumstances. And finally, from good leadership, said, no, we are joint, and we're going to do everything we can joint. We're going to contract jointly. We're going to purchase jointly. We're going to do that. And that's what has to happen. There has to be leadership that says, here are the problems that we're experiencing, and now how are we going to resolve those? And it may be coming back to us and say, the way you think they can be resolved is not the way that they can be resolved. But are you listening also to those that serve? For instance, I think Walter Reed, you know, there are reports that there's a high turnover, that if you have this confusion of command and control, then how does that play out on a day-to-day basis with those medical health care deliverers, and certainly the patients that are there? And oftentimes it's at that level they say, hey, this doesn't work. And so we're trying to work around an unworkable situation. So I would hope that if there are successes, and General Green, you talked about those successes, for goodness sakes, let us know that, So we can walk out of here at any other meeting with a better picture of what's happening than we have today. And where it's not working, then for goodness sakes, let's work together to say it has to be done this way. If not, it will deteriorate instead of saving money. It won't save money, but it can very, very alarmingly affect the healthcare, delivery of healthcare. So I don't have a question. That's just my observation and concern. Thank you, Mr. Chairman.
Ms. Granger, Mr. Moran.
Thanks, Mr. Chairman. When I was in pre-med and in Air Force ROTC, it struck me as strange that we had no cooperation or collaboration with the Navy Marine Corps ROTC on campus, because we were told that the culture and the mission were so different. But certainly the mission of healing the human body is identical. We took the same education training, the same procedures were to be applied. Since DOD was put together in 1947, there have been 10 reports that have strongly recommended an integration and unification of the military health service function among the services. And in 2005, GAO identified DOD's healthcare system as an example of one of the key challenges facing the U.S. government in the 21st century to achieve economies of scale and improve delivery by combining, realigning, or otherwise changing selected support functions. I could go down a list of other studies, but they reach consistent conclusions. It doesn't make sense to have a separate medical care among the services. And so the combination of Walter Reed and Bethesda was to be the national example, international example, in the nation's capital of how we would do that. So it's a bit frustrating when we hear reports from folks who allege to know and would have reason to know what they're talking about, and I put in quotes, dysfunctional leadership arrangement is a term we're told, at the combined Walter Reed campus. So let me ask General Horoho, who wasn't even alive when I was taking Air Force ROTC in pre-med, I'll bet, and Vice Admiral Nathan, do we have a patient-centered, collaborative, joint armed forces healthcare campus at Bethesda?
Do you want to answer first?
Thank you, sir, and it's a very important question. Yes, we have a great example of a jointly staffed facility that by and large is taking as even better care, if I could say that, of patients than they did before, because they're finding collaborative practices now that they're under one roof, and the Army is seeing things the Navy did that they like, and the Navy is seeing things the Army did at Walter Reed that they like. That said, this is, as I said before, this is a new paradigm. The command and control, which for Walter Reed Army Medical Center rested entirely within the chain of command of the Army to the Secretary of the Army, and of the National Naval Medical Center, which rested through the Navy Surgeon General to the Chief of Naval Operations to the Secretary of the Navy, now resides under the command and control of the Joint Task Force, the commander of the Joint Task Force, and we all recognize that, who works directly for the Deputy Secretary of Defense. So the services now no longer have full cognizance of or control of that system. So they are looking for ways, since that chain of command, a Joint Task Force commander reporting to the DepSecDef, is new and doesn't have some of the administrative robustness that the services had before when they each owned each hospital.
Well, I don't want to interrupt you, and we do seem to be repeating ourselves, but it's 65 years now that there has been a consensus that we ought to combine our military medical services because the mission of healing the body is the same, the procedures are the same. This is supposed to be the best example, and it seems to fall short. Let me ask you, is the commanding officer a rotational billet among the services?
Yes, I mean, the commanding officer at this time is Admiral Mike Stocks, and then it's not codified yet as to what the rotation is, but it's presumed that the next commander of the new Walter Reed would be any service, best qualified candidate of any service.
Well,
and sir, if I may, just to say, yes, there are growing pains there. You, all the members here have been personally interested in this, and you've come out and you've walked the deck plates, and you've heard some of the staff and perhaps some of the patients complain about, boy, we didn't do it this way at Walter Reed, or, we used to do it this way at Bethesda. And that's the cultural integration that has to occur. Some of that is the cost of business. But there is, as I've just stated, this is a new chain of command format that presently has not been precedent in military medicine. And so they're finding their way through it. Part of the task force, the genesis of the task force, was to see how they could move from this paradigm of a joint task force reporting directly to the Deputy Secretary of Defense to a more codified organizational table that you're looking for.
Well, is the TDA for Walter Reed Bethesda a joint document? It's not.
Not that I'm aware of, no, sir.
Yeah. Well, see that if the table of distribution allowance, if it was joint, would require the integration of all Navy and Army personnel into one joint command document. Admiral Madison, do you want to address that?
Yes, Mr. Moran, thank you for the question. There has been a decision by the department that these facilities would be manned on a joint table of distribution. Because
But they are not now.
They are not now. We have put them all on what's known as an intermediate manning document. What we wanted to do was to allow the flexibility in the first year in operation to make sure we were able to adjust between the hospitals if we hadn't gotten it quite right, if the organizational structure or the people weren't assigned in the right place. But the current decision is that they would be manned on a joint table of distribution.
They will be, but they are not. Okay.
But there are MOAs between the JTF and the services for all of the military people assigned.
Let me just ask a very simple, is there a cross-service medical personnel standard? Is it the same across the services? General?
Sir, when I just spent 4 months in Afghanistan, and I can tell you at the point of health care delivery and in a deployed environment, having Army, Navy, and Air Force working together, one standard of care, one chain of command, and everybody working together for a common mission. So we absolutely know how to do jointness and provide care.
I know you know how to do it, and in a combat situation in Afghanistan, you do it. But the problem is, back at home here, where we are trying to implement something that we've known was going to happen for some time, we're not necessarily doing it because we don't have the personnel and the line authority, et cetera. That's the purpose of the hearing, is it not, Mr. Chairman?
Yes.
Well, yeah. So why can't we do here what we have to do in Afghanistan and actually do quite well?
Well, I would say part of it is the unity of command and having, we have different processes for credentialing, different personnel systems, which is why we went to the DOD civilian personnel system, so we had one standard for our civilian personnel. This is a maturation process that we have to identify what are all those business processes and standards that are different. Delivery of care is not different, but the way that we manage is different, and those we have to find that commonality for shared services.
Well, I think my time is up. But the professionalism, the quality of the personnel is terrific at Walter Reed and at Bethesda. So this is no slight as to the excellence of the people assigned to this duty. but there does seem to be a shortfalling, a deficiency in terms of the administrative structure that they are governed by. I don't have a problem with joint task force. It seems to me that was the most expedient way to do it, but it seems as though these growing pains are going to have to be dealt with on a more expeditious basis, perhaps.
Would the gentleman yield?
Yeah, sure. I mean, it's the chairman's time, but
No, sure, you yield.
General
You yield?
Rowe,
Yeah, yes.
yes.
what I don't understand, let's talk about Afghanistan. If you have, say, a soldier in the Army who's injured by IED, from there goes to Landstuhl, from there Walter Reed, where does the difference begin? Let's say that there was a soldier and a Marine, both injured, same accident, similar injury, they're side by side in the field, and then do they get separated in Landstuhl? Do they get separated at Walter Reed? And when does the paperwork start deviating? And do they both have that microchip in their uniform that gives their blood type and their medical history? You know,
They, not that I'm aware of on the chip
okay.
right now.
But so where do the
But I'll
two
get
of
back to
them who are side by side, injured in the same accident, where does it start to split? And Mr. Moran's question.
As they get transported out of Afghanistan and going through the system, commonality through
The
launch-
minute they leave theater?
No.
Or-
What I'm just taking you through.
Okay.
So there's all the way through, and then they can, when they ride back in the continental U.S., if they arrive and they get assigned to Walter Reed National Military Medical Center, then there is a chain of command falling under JTF Camp Med. Or if they went to Brooke Army Medical Center, then there's a chain of command, which is Air Force and Army working together under a different set of business rules. Or if they go out to Madigan Army Medical Center, there's a different chain of command, which is a straight Army chain of command. So it really is in our overall governance structure of where things are different. But the delivery of the health care is the same across the board. If you go to any one of our military treatment facilities, sir, whether it's Army, Navy, and Air Force, we are joint at the patient care because we treat Army, Navy, and Air Force. There's not a single hospital that only treats their own. And so we base our care on demographic patient population, all having business plans, doing the analysis, working to try to pull more work into our military treatment facilities, vice into the civilian sector so that we're more able to manage the cost containment of health care. And even looking at shared services with the VA where we can better collaborate in certain geographical areas. So that work is ongoing, but it's the governance structure of each of those that makes the difference.
If I may add to that, the reason for the unity of command that you see in deployed environment is because of the combatant commands. And so it is CENTCOM that actually establishes what the medical guidelines will be and how the evacuation system will work, and basically drives that unity of effort until they get back to the states. And once they get back to the states, they come back into the service systems because there is not a unified command that has oversight of the U.S. When you look at Goldwater-Nichols, it wasn't established purposely, and now the NORTHCOM is in place, but NORTHCOM does not have oversight per se over the services. They have components that have specific purposes, but they don't oversee the services as they deliver all services, including health care. And that's why you don't have the same unity when you get back to the states.
Well, it bears noting, Mr. Chairman, that at Fort Belvoir, it's actually working quite well. We have not received one single complaint. It's under Army command. It's working beautifully. I don't know why that is not necessarily the case at Bethesda. I think it's just something we need to look into. But it bears noting that Belvoir is working just fine. No complaints whatsoever. So thank you, Mr. Chairman.
Mr. Calvert.
Thank you, Mr. Chairman. Good morning. I want to thank you for your service and your leadership. We certainly all appreciate you. But before I get my line of question, I do want to make a comment. If the traffic management and parking arrangements at the merger of Bethesda and Walter Reed is any evidence of what's going on inside, we're in trouble. Several times I've been there, it's been difficult. In November of 2000 and what? In November of 2006, the Deputy Secretary of Defense approved a plan to consolidate common healthcare services functions, finance, information management, technology support, logistics, the rest of it. In 2007, the GAO criticized the plan because DoD had failed to do a cost analysis of this merger. May 24th of 2011, the administration said DoD would shortly complete a study on how best to deliver high-quality medical care to service members and their families in an effective and a cost-efficient manner. On September 29th of 2011, the Task Force on Military Health Care System Governance released its final report, recommending that a variety of health care support services, as we've been discussing, be consolidated into a defense agency, DHA, including finance information management, as I mentioned earlier. The recommendation, therefore, is essentially the same recommendation that was made 5 years ago, and it still does not have an estimated cost savings analysis that has been completed. So I guess the logical question would be, has any, I heard mention of a consolidation of a call center, but has any consolidation of health support functions occurred since November of 2006? That you're aware of? And if not, why not?
Sir, in the NCR, I think is the example of where we've had consolidation. And I'll give you an example of the power of being able to work across services with the right authorities. We had two hospitals, very large size, that needed to be outfitted. That is, we have to buy all of the equipment that goes into them. And one of them was an Army hospital at the time, one of them was a Navy hospital. We were able to consolidate those two contracts. It was a cost estimate of about $393 million.
The extent of consolidation?
We were saved over $77 million just by consolidating the contracts, and then in execution, we were able to save an additional $39 million, another 9% on the contract cost by having the authority to be able to consolidate some of those shared services, if you will. And part of the response, I think, to the GAO report is what has happened in the NCR in terms of being able to achieve shared services.
So NCR is the
National Capital Region.
Is that the only consolidation that took place?
No, sir. You consolidated the two large hospitals in San Antonio with Air Force and Army coming into one, saving about 500 manpower positions. And they now work under a structure that is overseen by the Army in the large facility. In other words, works by their system and has a market oversight that is shared between the Air Force and the Army. You've also seen consolidation in Alaska of services there. You've seen consolidation at Pope and also out at Madigan and McCord. There's been consolidation and closure of hospitals in Colorado Springs. Now, many of these are BRAC in terms of what was driven by BRAC, but there's been a great deal of consolidation. The November 06 memo that you're referring to was
when you say a great deal of consolidation, I mean, we're sitting here, I guess from my perspective looking at this, I don't see a great deal of consolidation. And if consolidation is being done and you're analyzing costs, why wasn't a cost analysis ever done?
I can't answer why a cost analysis wasn't done. I think
how do you know really? You know, I'm a former business guy. I came up here. I mean, I just look at it from a business perspective. How do you really know what you're saving unless you do an analysis of what you're doing?
We agree. We're not disagreeing with you, sir. The November 06 memo was overtaken by events at Walter Reed and the establishment of the JTF. And so you didn't see some of the things that were proposed back in November 06 because of the efforts that went into basically trying to improve the wounded warrior care.
The position of this committee, since the task force recommendation largely just rubber stamps a decision that was made 5 years ago, why should we believe any changes are only going to be made this time? I mean, to the extent that we'd like to see made. You know, we're talking about difficult decisions that this committee is going to have to make shortly. Right. And we've got to have, I think, pretty good evidence of how we determine what those final decisions are going to be. And I don't see any great evidence on how to how to move forward here.
I think that the Department of Defense would share your frustration in terms of not having all the information that they would like to have to determine how to go forward with this. And so, again, we can give you our personal inputs on what should be done, but it's hard for us to speak for the department when there's not been a formal decision with regards to what their recommendations are going to be on the task force. The three of us as Surgeon Generals before you understand completely that we need to collaborate and find ways to basically be more effective and efficient as we provide quality care and take care of America's most precious resource in terms of the people who've defended this country. And so we're with you. We can't say why the department does not have the cost data that you require right now.
You know, I guess I just frustrated at 5 years and where are we going to be just here in 5 months when we're going to have to make some difficult decisions with the chairman. So that's the extent of my questions, Mr. Chairman.
Thank you, Mr. Chairman, and I want to join everybody else. Just thank you very much for your service. And obviously, you look at survival rates and you look at disease rates, and you know we've been in 2 wars, and you've done an extraordinary job. And a lot of us had an opportunity to visit a lot of medical facilities, both in the field in Iraq and Afghanistan, and in the various way stations. And the care, the compassion, the focus on helping wounded warriors through this is remarkable. So thank you very much. Having said that, I think I'm like the rest of my colleagues. A lot of the presentation, and perhaps because I don't know a great deal about healthcare, sort of opaque. I mean, I don't think we've really gotten a lot of issues defined as to what the big challenges you're facing are. I mean, there's a lot of rhetoric, but back to Mr. Kingston's point, not a lot of specifics, this to this, this to this, and I think we probably need a little bit more of that going forward. Let me focus on a couple of areas that I have particular interest in. One, just out of curiosity, do the three of you meet regularly? I mean, do you have like scheduled meetings where you literally sit down and the same way the Joint Chiefs do and think, okay, these are the common problems we have across the service?
Absolutely. Yes, sir.
I mean, pretty frequent?
If I could be so bold, I think that the three of us have energized actively collaborative meeting and spirit that I think sets the bar so far.
That's great. That's good to hear. Thank you very much. Second question, and this maybe is a premature question to be fair to all of you, because we haven't seen the budget yet. We all know we're going to be going through a downsizing over the next several years. We're going to have pretty difficult decisions to make in that regard. You've developed some astonishing capabilities, and they've not only served us very well on the battlefield, they've served us very well in other areas. The work that's been done by military people during the Haiti and have really helped the image of the United States of America. So I'm concerned as you look forward, what kind of downsizing do you see in terms of your capabilities? What are you most concerned about losing, if anything, in the next several years?
You want to just go straight down this way?
Sure, go ahead.
Okay. Sir, my biggest concern is as we reshape the Army and we have troops coming home and longer dwell times, we're going to have a large population that we will still have to support with either behavioral health concerns or traumatic brain injury and concussive care. And so it's ensuring that we have that capability for the period of time that we're going to need to. So I think there's going to be a period as we draw down on the number of troops that we'll have a large number that's still going to require care. And so the effort that I have ongoing right now is analyzing what capability do we need, where do we need it, and ensuring that we have that available for the out years.
Sir, I would echo that. Regardless of what happens to our medical footprint in the services, the health benefit requirements will probably stay about the same. And so how do we balance what we do within our own system with what we send outside of our system to the networks, to the private care sector, which can be pretty expensive. So we have to look at that. And then from a Navy perspective, as you mentioned, we're one of the quivers in our that we have to draw on is humanitarian assistance, disaster relief. These missions can be expensive. They can be sometimes material intensive and personnel intensive, yet they do a great deal of good, and they're wonderful venues to show the ambassador the ethos and the compassion of the U.S. to other countries. And so we're monitoring that closely to see just how much we can afford of that and try to maintain that presence.
When you deal with one of those, I'm just trying to remember myself. I mean, how often have we recognized that from an appropriation standpoint, that we've put an extra unanticipated burden on you and help defray that expense, or do you just sort of have to eat the cost?
Well, there has been appropriated money for those missions, and we're looking at now in the Navy, for example, the hospital ships extending their shelf life, looking at how we can build, if we can build newer platforms to maintain those missions, at the same time sharing a warfighting responsibility. As many of our Greyhold warships now do, they also carry humanitarian packages and often put into port to do humanitarian work, which we think is great bang for the buck. So again, Congress has formally recognized those programs.
And I think that we would echo what my two counterparts have said. I would tell you that as we come out of the war, one of my major concerns is, because we have downsized our hospitals so significantly, that we need to be able to maintain these skill sets of our folks to take care of trauma and to do this critical care that's been so vital in this war. And so we've been doing a lot of partnerships with local universities, making certain that our folks are working in level 1 trauma centers, et cetera. And the other side of that is that because of the war and the focus on the deployments, we also need to make certain that we're offering the kind of care that everyone wants to come back to. And so we're looking at how we bring people back into our system to keep our hospitals as robust and as busy as we can, because we know that physicians who have a busy practice are more likely to stay with us.
Please.
Thank you, Mr. Cole. One comment from a strategic perspective. There's been a shift during this war with the great work that the critical care air transport teams have done in being able to move critical care patients back from theater. It used to be that we had to put out deployable platforms that kept them in theater for 2 or 3 weeks, sometimes a month, before they could be coming back as they were in past wars. Thanks to General Green here and so a lot of great work in the Air Force, those things started up with Operation Iraqi Freedom, and we now no longer have to have the number of deployable platforms that we did. But those patients are still in beds for the same length of time. Doesn't shorten the time that they're requiring care. And those beds are now here or in Landstuhl. And so we have to make sure that we maintain, as General Green says, I think, the number of beds that we need to be ready to take care of the casualty flow of the future.
Two other quick questions, maybe not too quick, but obviously you've got patients, particularly critically wounded patients, that go through a continuum from battlefield to transportation to Landstuhl to back here. A lot of those folks, of course, eventually leave the service. How comfortable are you that you're coordinating well with the veterans facilities and the care that they're headed to next? I mean, there's obviously a lot of opportunities along the way for somebody to slip through a crack accidentally.
I think that the work we're doing to improve the integrated disability system is helping with coordination with the VA. I think that the work we're doing with the integrated electronic health record to get to a single health record will take that much further. I think that there's a spirit of collaboration, and it's been steadily improving in terms of eliminating seams between the VA and DOD to make certain that we don't lose somebody, that they have care immediately. And so we've been a lot of progress towards that, but I think there's still work to be done.
Last question. Thank you, Mr. Chairman. You've been very gracious. One of the areas that I think has concerned this committee, we've learned an awful lot more about head injuries in the last decade, both at peace and at war, than we've known in a long time. And I know there's been several efforts to have little testing, joint centers to look at this. I've never been 100% convinced we've really gotten to where we need to go, and both in terms of before and after testing for people as we deploy them into combat theaters and best practices once they get back. So I'd just sort of like a quick update from you on what we're doing on head injuries and post-traumatic stress for that matter.
Okay. Sir, I'll start in Afghanistan if I can, and then kind of bring you through. In Afghanistan, we now have 11 concussive care centers that are jointly manned, one standard of care, and this has been implemented over the last probably 12 to 18 months of having a DOD standard for how we manage. And so if someone is exposed within a 50-meter radius to an ID blast, they are evaluated with a concussive care evaluation. They have mandatory 24-hour downtime, and and then we have 3 neurologists that are in theater. So if they need to be evaluated because the symptoms show that they have a concussion, they're then treated within these concussive care centers and can be there several days or up to several weeks.
Are you comfortable that you've got a baseline? Because we're, again, we've been sort of round and round about this, and I'm not pointing fingers at anybody. I think we're all struggling to try and figure out what the appropriate things are, so that when a soldier has an incident like you just described, that we know sort of where they started, so you've got a comparative point of reference?
We have everybody that's taking the ANAM, so they're being evaluated 100% before they deploy. They're being reevaluated when they're exposed, and then that's documented both on the blast exposure side and then also on the medical side, so that we can kind of cross-reference and make sure that someone hasn't dropped through the cracks with that. We have a 97% return to duty rate of those in theater that have been exposed to an ID blast. And then we've also worked so that we have one standard of training for Army, Navy, and Air Force pre-deployment, so that everybody's implementing the concussive care clinical practice guidelines the same way, and then having that capability back within our military treatment facilities. And then we also have, we're standing up various satellite clinics to look at concussive care that actually marries up to the NICO Center that's on the Bethesda campus.
Thank you very much. Thank you, Mr. Chairman.
Mr. Hinchey.
Thank you very much.
I should say the patient, Mr. Hinchey.
Pardon me?
The patient, Mr.
Yes,
Hinchey.
indeed. Thank you very much. And I deeply appreciate everything that you do. And all of those things are critically important, of course, and they have a big effect on a lot of people. And I very much appreciate the answers that you've had to the questions that were set forth. I have just a couple of simple things to ask. The circumstances that we're facing now have a good number of people who have had experiences of physical and psychological in the context of the wars that they've been engaged in. Particularly, I guess, Iraq and Afghanistan recently. Those people, a lot of them are located in places that are remote, even in a place like New York and in other places across the country. What is going on to try to help them, to try to get them to the kind of circumstances that they need? I know that there are a lot of people who are really necessary to get this kind of attention, but so far a lot of them aren't. What can be done to deal with it? And frankly, I understand also that the base realignment and closure is a situation that is reducing this whole operation. And I understand that there may be some more of that. So what is going on with those kind of circumstances, with those people, in those kind of rural areas, and the physical and psychological efforts that they have suffered in the context of the... Thank you. The context of the... Oh, very good. In the context of the operation that they've been engaged in.
Well, I'll start, Mr. Hinchey. 2 aspects that we worry about. One is we think that people are getting leading-edge care for post-traumatic stress and traumatic brain injury in these epicenters of care, such as Walter Reed and San Antonio and San Diego. So how do we make sure that they get that kind of care with some of the advances in some of the spaces you talked about, where they're away from that? And then secondly, the administrative support. What is their management of care? How do they get the appointments they need? How do they get the proper follow-up with the right kind of people to do that? One of the things we've done is create the National Center of Excellence for TBI, the NICO, that exists on the Bethesda campus. Its purpose is threefold. One is it has all the latest and greatest diagnostic and therapeutic materials, but it treats a small cohort of patients. It's not designed to take care of the enormous numbers that my colleagues have talked about that we're going to be facing in the coming years. But it's looking at ways to find recipes, if I may, for better treatment of PTS and TBI, and then exporting that. It has its second purpose is research to collate data from our patients. Our patients are unusual because, unfortunately, becoming too usual, but unlike motor vehicle accident patients or trauma patients in the States, most of our patients are suffering these concussive injuries that General Horoho was talking about, and how to approach them and recognize them both in the near term when they suffer some problems, and then latent periods where maybe years later things will start to pop up, and how do we catch them and what safety net exists for them. Right. And then finally, the third is a collaborative mission of the NICO, and General Horoho was talking about the satellites that are going to be created throughout the country on a smaller scale of these. The collaborative initiative, I think, is the most important. It is the one that is bringing together the private, academic, and federal sectors to partner in this care. We cannot do it alone. I'm the first to say that the military cannot be the sole provider of care for these TBIs, nor can the VA. It's going to have to be a national call to arms among the private academic sectors. We're starting to see some of the nursing schools change their curriculum to add traumatic brain injury and post-traumatic stress as part of the curriculum, so that nurses will be more attuned to that as they go out through our society. Medical schools as well. The progress is slower than we would like, but I think there is an initiative. We're having VA-DoD cooperation now with the VA-DoD partnership in North Chicago, where we're finding a same electronic medical record. One of our big obstacles to this kind of care and managing patients across the spectrum is finding a common medical record that can be easily used by both the VA and the DoD. So the VA can see exactly what was done in the system, and we can see what was done in theirs. We're working on that. And then there's the case management system with the federal healthcare coordinators that now overlook both the DoD and the VA and other federal care facilities as the patient goes back to New York or goes back to Bremerton or somewhere else where they're away from the mothership. So we're all, I think if you ask all of us, we're still frustrated with the progress that's made. It is the most vexing injury and problem of the war from that standpoint. But yet, I think we're making progress. I do believe we have to get more and more collaborative integration among the private, academic, and federal sectors.
Well, thanks. The situation I think that you're describing is going to be even more and more difficult as time goes on. And it's going to be more complex and more complicated to deal with. What do you think we would have to do? Is there anything that any contribution that this operation can make to make this situation better? And I mentioned that the base realignment and closure is not having a positive effect on the long range of the situation that we have to deal with here. What can be done to alter that, to make it more effective, to make the people, a lot of people across this country who need to get attention, who are not going to get it unless the situation is dealt with more effectively?
Sir, one of the things that I just want to bring out that Congress did recently just gave us, which was the legislative authority to credential and privilege mental health providers across state lines. And what that is going to allow us to now do is to tap into that capability and get to some of those remote areas for our reserves and our National Guard in getting telebehavioral health out there. We're using telebehavioral health and have been over the last couple years to treat the large volumes of patients that we have within the Army and also in a deployed environment. But it's looking at those legislative requirements that where we can maybe break down barriers on how we provide care within the civilian sector as well as partnering with our military.
Yeah.
In my role as the co-chair on the Recovering Warrior Task Force that's looking at some of the programs, there are a lot of innovative things that are being done with both non-medical and medical case managers to do outreach for people who've been identified, as well as the work of all the services to basically keep registries of wounded warriors so that we can follow them. some very progressive programs in terms of the Army's community-based warrior transition units and also the Marine outreach to some of the communities as people separate. I think that you're going to see the veteran service organizations very busy again in terms of taking care of reservists and guardsmen who may be in faraway places, and the VA has outreach programs. And so I guess what I would tell you is to watch these things to see which prove to be most effective as you talk to your constituencies and see those things. The real hard piece now is making sure that these services are visible to people so that they know how to interface with the system and get the help that they need, because all of us are concerned that as we see the end of the wars, that we will see a rise in post-traumatic stress. Whether it rises to disorder or not, we don't know, but there are many people who continue to serve. In fact, I would tell you that in our numbers in the Air Force, 70% of people diagnosed with PTSD are actually maintained on the books and returned to duty. And so it's one of those things where we're going to have to continue to deal with this, and our outreach programs to the Guard and Reserve are going to have to remain robust.
Yes. Well, I appreciate that, and this is something that has to be done, and I think it's going to be more effective if there's a good sense of cooperation between the operations here. I also understand that there's a TRICARE Prime remote operation, and there may be some others, and that is having a positive effect. Could you tell me something about that and what the positive effect of that is and what the likelihood is of more expansion of these likely effects?
Well, TRICARE Prime Remote is simply a system that allows an active duty member, an active duty family, to choose a physician in the local area when there's not a military system there to take care of them. And so they basically designate who their primary provider will be, and then they can establish a relationship. And so our managed care support contractors work to establish the network, and of course people then sign up. If we diminish our presence somewhere where we can't take care of them, there is a network today that basically is available to the TRICARE Prime Remote for those people who are designated that way. It tends to be used more for recruiting stations and for those folks, relatively small numbers of people who are in far away working in cities to recruit new people into the services, but it can be used for anyone who's in a geographically remote area from one of the service facilities.
Gentlemen, yield just for a second.
Yeah.
Does this relate to the Guard and Reserve as well? Are they eligible? Is this active duty?
It's really designed for active duty, but there is a continuation of TRICARE benefits, as you know, when they separate from the service, or actually if they're in a status where they're being retained on active duty. So during the time that they're on active duty and for a period of months after they separate, they are eligible to be signed up into the TRICARE system, including the TRICARE Prime Remote.
Thanks. Well, thank you very much. I very deeply appreciate everything that you're doing, and all of that appreciation is very clear from all of the answers that you've given to the complex questions that have risen here. There's an awful lot more that needs to be dealt with, and anything that we can do, I think, to be helpful would be useful. I think there needs to be some more cooperation here, intelligent cooperation, about the circumstances so that we can deal with this more effectively. And thank you very, very much. Thanks for all the responses that you've given and for all of the positive things that you're doing. I deeply appreciate it.
Thank you, Mr. Hinchey. I have to go back to General Green. We have talked a lot this morning about consolidations, about mergers, about jointness, and things apparently work very well. But from time to time, there's a little friction when you do, and you said that yes, there were some examples of friction, and I think that might be an understatement. The major focus on merger right now is Walter Reed Bethesda. I can tell you that there is friction at Walter Reed Bethesda. I think the Army and Navy have worked very well together to do what they do best, and that is to create the organization that they're called upon to create, work out the problems, and if we did it one way at Walter Reed and one way at Bethesda, we end up doing it whichever is the best way of the two ways. the friction, and no personalities involved here, please, Admiral, understand this. The friction is between the established military and the JTF. And I think anyone who knows anything about this and is willing to be honest will admit that there is some serious friction with the JTF, with JTF countermanding decisions made by Walter Reed Bethesda, with personnel issues, and I don't know if there's some way to work this out, but I think it's got to be worked out because I did not bring a lot of anecdotal names and addresses and stories, but I can tell you that there are a lot. Now, of all of the other collaborations and mergers and work that you have talked about today, which you're proud of it and we're proud of it, I did not detect the presence of a JTF type organization anywhere except Walter Reed and Bethesda. So I'm just wondering, are you Surgeon General of the Navy? Are you Surgeon General of the Army? Are you basically being replaced in your role of authority by JTF? Or have you worked out some kind of an accommodation?
JTF has been given OPCON, or Operational Command, over the Walter Reed National Military Medical Center.
I'm aware of that, yes, sir.
So they are responsible for the daily mission there. The Navy retains, because until told otherwise, it is technically still a Navy command and facility, recognizing it is jointly staffed and recognizing it is jointly led, and recognize that it has operational command oversight by a joint task force. The Navy retains administrative control, as Admiral Madison spoke about. That has to do with personnel issues, pay issues, fitness report issues, all those various things that support it. There has been friction over what is ADCON, administrative control, and what is OPCON. And there have been discussions and disagreements at times with the JTF over whether or not they are now, the JTF is usurping authorities that really come under the administrative control of the service in providing its mission there. Always recognizing that the Army personnel there need to be given complete understanding and entitlement to those personnel policies which are germane to them, because this is a one-of-a-kind right now. I mean, Belvoir, it was brought up earlier that Belvoir doesn't have as many problems, but Belvoir really has only a small percentage of Navy personnel there. Walter Reed is about 50-50, and at Belvoir it's about 80-20 or so. And so recognizing that when people leave in the current system, when a staff member leaves Walter Reed Bethesda and goes back to any other facility, they're going back to basically their home port service facility. And so they have to adhere to certain administrative policies which are lie resident with their own service. So that is where the majority of the friction has come, defining what is really operational control and administrative control, and then trying to understand exactly the complete chain of command for who's responsible for that policy.
Is Fort Belvoir under jurisdiction of JTF?
Yes, sir.
Anything else besides those two? Chairman?
Well, I asked at one point earlier on if there was a decision to reach out and bring in other organizations, and the answer was no, not at this time. I think that was the answer, Admiral, that you gave. Is that friction going to work out? Can you get this resolved? It's pretty serious,
Sir, I would tell you, most of you have probably visited Landstuhl. Landstuhl is, without being designated a joint facility, it is an Army facility run by Army rules that has both Air Force and Navy. Air Force has been in that facility now for almost 14 years. And so with any new system, until you understand what the rule sets are and how it will work, there's going to be friction. And frankly, I think even when you talk with us, we're like siblings. From time to time, we have rivalries. Okay.
Sure. Well, I understand that.
Okay. And so I think that it does get better with time. So Landstuhl is functioning very well. Down in San Antonio, it's not quite as much friction, perhaps, as you see up here. But if you looked, if you lifted the skirt, you would see that there are frictions there as well in terms of Air Force not understanding why the Army does something a certain way. But over time, we'll find ways to integrate and do these things. So the answer is yes, over time. The harder piece is your question regarding what should be the oversight. And it really has to do with joint doctrine. I would tell you that I've watched this closely and watched the evolution of the doctrine to see how we would deal with joint bases. And there are very similar issues going on with joint bases because we tend to execute by service because that's the way it was set up back here in the States. And so getting to what the right level of headquarters should be there, and again, if you don't like the JTF, then one of the problems is when you establish a joint headquarters for all the services, essentially you're also establishing another layer of oversight. And so it's really a question of what do we want as a nation, and then how do we proceed to make this clear to everyone so we all understand the rules, because we will salute and make it work.
Well, I think it's very interesting. The task force, not the joint task force, but the task force that came up with 5 options as to how to proceed with this governance of the merger. The Army and the Navy are major players here in this particular merger. It's interesting to me that of the 5 people who voted their service or their organization, the Army and the Navy both voted for option 2, which did not include JTF, which included a joint structure between the Army and the Navy who are merging their 2 hospitals. And BRAC is supposed to eliminate functions or consolidate, not to create new functions or new organizations or new bureaucracy. And so I do have a little bit of a problem with this, and I do believe that there is more friction than has been acknowledged at the table today. And I also know that friction will cause a deterioration of health care. And the one thing we don't want to happen is for a medical professional here or on this side of the bed, because of a friction, offending a patient or offending a patient's family. And that does worry me, because if the care of that soldier is affected, and as you know better than I do, that these kids are hurt really bad, and they're not kids really. Chronologically, they are, but after what they've been through, believe me, they're not kids, and we just can't risk doing anything that is going to affect their care and their treatment. We owe them a lot. I've had my say. It is not personal with anybody involved with JTF or anybody involved with the merger. I just am concerned that friction by General Green was understatement, and I think there's a lot more friction, and I think JTF is a major part of it. And so, now, Mr. Dix, do you have any closing thoughts?
I got a couple things I wanted to go back with the General Horville. And we've been told that one of our major efforts has been to tell the soldiers that they should seek care if they think they've got a traumatic brain injury or post-traumatic stress disorder. Now, I'm told this, I want you to think about this. Is the Army advising the soldier that if he claims PTSD, it could affect his future in the military?
I have never heard that statement, sir.
Or could affect him as a civilian?
I have never, we've had our senior leaders come out who have actually sought care themselves and have gone on to get promoted. So it's been a campaign across all of Army for people to break down the barriers and seek care. So I have not heard those particular statements.
Now, on the return to duty, I mean, I can understand, when you go out to Bethesda or Landstuhl, the first thing these kids say is, I want to go back to my unit. I want to go back to serving in the military. So I don't have any, I understand why the soldiers would want to do that. How long, and these examinations, when they're looking at these disability benefits, how long are the sessions when they meet with the doctor?
There's a couple sessions. We have a comprehensive behavioral system of care, so it's mandatory that 100% of our service members that are redeploying back, that they have at least a 45-minute face-to-face evaluation. And so that's upon redeployment. And then we have 5 different touch points that occurs over a 12-month period. And then if they determine that they need further care, that initial evaluation, then they either see a psychiatrist, a psychologist, psych nurse practitioner, or a primary care trained in behavioral health. And those sessions are determined based on your clinical symptoms.
Okay. Well, again, I hope that we can get to the bottom
Yes,
of
sir.
the thing. I just, again, we appreciate the good work you all do, and we want to make sure these kids are taken care of. That's our motivation. And on the Joint Task Force, what is the future? What is the future supposed to be of the Joint Task Force?
Mr. Dixon?
Is it going to be there forever, or is it going to go away?
It was chartered as a standing joint task force, and so there's no sunset clause, no go-away date. Ultimately, it will have to follow what happens with the rest of the MHS governance decision.
Yeah. All right. Thank you, Mr. Chairman.
Okay, Mr. Frelinghuysen has a quick follow-up, as does Mr. Kingston.
I'd like to put a finer point. Could you provide us where we literally stand on electronic medical records? I mean, I think the VA is there, but there seems to be quite a gap. I don't need to hear, but just for the record, I'd like to see how close we are. Many of us go out to Walter Reed. The medical review panels that a lot of these soldiers are, subject to, is there any uniformity in the services relative to those types of decisions? Just for the record as well. Yes, sir. Admiral.
Yeah, the differences, are the different disability evaluation systems that each of the services has. There's been a great deal of work with those systems and with the VA to make sure that by the time somebody leaves active duty, they've got both a VA determination and a DOD determination.
Just one other comment. I know I visited both the Marine and Army PFC. Changeover of doctors. I mean, every time I go out there, they say there's another team. They're all excellent MDs, but there seems to be quite a turnover of military doctors, and that's a concern. Let me put in a plug. I guess, is the mail system screwed up out there? I'm hearing from some of the soldiers that they're not getting their mail. That's pretty essential for the record.
I would say that's an ADCON responsibility that belongs to the Navy.
Whatever it is, let's get it resolved. Thank you, Mr. Chairman.
Thank you, Mr. Chairman, and I guess I have 5 questions for the record. Number 1, if you could get an organizational chart to me, that would be extremely helpful. I think other committee members would like it, but I would specifically like it. And don't kill yourself in terms of the details, but the personnel in each box or the budget, that would be helpful as well. And that would be kind of the before and after organizational chart. Then secondly, in terms of the recommended changes to the governance structure, especially the ones that will require an increase in budget or an increase in personnel, could we see what the impact on the ability of the MHS to effectively and efficiently utilize and integrate and procure interoperable technologies to maximize the purchasing power? I'll submit this to you in writing, but the measurement of what kind of impact that would have would be helpful. Then number 3, The task force only allowed 90 days for the NCR, and was that enough time? The NCR part of the study, as I understand, only took 90 days. And was that enough time? And then in terms of the Joint Task Force on CapMed, did it actually save money? I'd actually like to know the answer to that, if any of you know off the top of your hand. And then my fifth question is, in terms of the consolidation of Bethesda and Fort Belvoir, they're complete, but there still are some outstanding projects. And what are the projects that are still outstanding, and what's the cost of those? So that, Mr. Chairman, I would like to yield back unless somebody could tell me if any money was actually saved, because I know the original BRAC recommendation was supposed to save money.
The return on investment payback period changed significantly, but there is a return on investment.
For the Bethesda,
For the
Walter
BRAC,
Reed
yeah, for the
consolidation.
infrastructure changes in the National Capital Region.
Because that was one of the outside reports, is that it was supposed to save a lot of money and it ended up costing $1 billion or something. And so I think it would be helpful for us to be able to answer that. Thank you. Mr. Chairman, I yield back.
Okay, thank you, sir. And I want to thank all of you for being here today and answering some pretty tough questions that we were curious about. We stand by as a committee to provide the best we possibly can for the medical care of our wounded soldiers. And of course, for those who are your retirees that you deal with, we're here to support. And we're here to do the best we can to help you do a good job. And now, Mr. Lewis, you have the last word.
Thank you, Mr. Chairman. Very briefly, 25 years ago, I found that the VA didn't seem to have a system to care very much long-term for the real care needs of local veterans. My staff accompanied veterans to the local hospital as though they were relatives. And this went on for about 2 months, Mr. Chairman. The director went through the roof when he heard about this. But my God, suddenly that VA hospital discovered the computer. And that was the beginning of what you described, the VA getting a handle on how the computer and otherwise can be used to have information flows that cross over territory, hospitals, and service delivery systems. We could learn a lot from that as we go forward with the project that you're about. That original change was not easy. Any change is difficult. But if we really want to maximize quality care, we've got to break down these barriers. And you're almost like yes people to us today, because you've got a mission, and people have suggested we're moving forward. We're not hearing very much about the problems, and I'll be asking questions for the record in connection with that. But no, it's going to be very difficult, and quality of care will be at risk if you don't break down these barriers. Thank you, Mr. Chairman.